Now I invite Ms. Fu Li Lian. She is going to talk about clinical best practices. Over to you.
Good morning, everyone. Thank you for coming for the lecture today. I'd like to thank Essilor, Dr. Kuna, organizing committee for the opportunity to be here, and thank Dr. Ramesh for the very kind introduction. So today the talk will be presenting on best clinical practices, particularly in implementing Stellest for myopia management. So these are my financial disclosure. So as mentioned, I'll be talking about the best practices using Stellest Essilor lenses. So what exactly is Essilor lenses? I believe Dr. Kuna has mentioned earlier, is basically controlled through the hot zone with 11 concentric rings of contiguous aspheric lenslet and generates a volume of non-focus light where slow down signal is in front of the retina. I'm going to present this study that was performed in Singapore National Eye Standard. It is a study basically about combination therapy, combining Stellest Essilor lenses with atropine therapy itself. And whether or not this will help to slow down the children in terms of myopia progression compared to just low-dose atropine alone. So the inclusion criteria in this study comprise of myopia -1 to -6 diopters, astigmatism of less than -2 diopters, children of 6 to 12 years old, and patients who are only on low-dose atropine, such as 0.01 as well as 0.025, with good compliance. And they must also have myopia progression of at least 0.5 diopters in at least one eye for the last 6 months. So what are the demographics of these patients that we have recruited? So the types of the study that we performed was a prospective, non-randomized controlled observational study. We recruited a small number of subjects, which is 50 participants, aged between 6 to 11 years old, with a mean age of about 9 years old, and gender-wise, about 40% of them are boys. We have a mixed ethnicity in Singapore with majority of the Chinese, and hence the subjects we recruited are very reflective of the population that we have in Singapore, with close to 90% of them are Chinese, as well as including Malay, Indian, and Eurasian. Atropine usage in these children comprise of 0.01 nightly, 0.01 twice a day. Usually we advise them to use morning and night, as well as 0.025% once every night. The data we have collected comprise of pre-treatment, which we collect the spherical equivalent and axial length data 6 months before the study, and treatment-wise, we collect during baseline 6 months as well as 12 months in terms of both spherical equivalent and axial length. What are the key results that we have? If you look at the chart, you can see that once we started hot lenses on the left-hand side, which is spherical equivalent, and on the right-hand side, change in axial length, there is significant in terms of slowing down the rate of progression in both spherical equivalent as well as axial length in these children after adding on hot lenses on top of their low-dose atropine. So in terms of numbers-wise, here are the results. Spherical equivalent and axial length. Pre-6 months is minus 0.6 diopters and 0.24 millimeters. And you can see the significant in terms of slowing down the rate of progression at 6 months and 12 months after adding on Stellest Essilor lenses. So in terms of percentage-wise, it is close to 90% as well as 75% at 6 months. And also taking average, it is about 75% in terms of spherical equivalent reduction and 42% in terms of axial length reduction. And if you look at the spherical equivalent change as well as the axial length change, there is a shift in terms of hyperopic shift, slowing down the rate of myopia progression. You can see that the mean spherical equivalent is shifted to the right side, and change in axial length is shifted towards shortening once we add on the hot lenses on top of children who are already on low dose atropine but have suboptimal progression. We do know that there are still 20% of the children who still progress more than 0.5 diopters over the last 1 year, and 18% still progress more than 0.3 millimeters in terms of axial length, and 40% progress more than 0.515 millimeters over 1 year. But having said that, we do know that children do tend to have some form of progression because they are still growing, and there's a baseline in terms of progression for these children whose axial length will still continue to progress to some extent. Based on multivariate analysis, the change in axial length, we found that they are greater for those patients who are on higher dose atropine. So for example, for children who are on 0.01 twice a day compared to 0.01 once a night, as well as those who are on 0.025% atropine. And also the change in axial length are also greater in younger children with smaller pupil size. After controlling various variables such as baseline spherical equivalent, gender, ethnicity, as well as baseline axial length. How about in terms of glare as well as peripheral distortion? Do these children experience any of this, you might wonder, after adding on the Essilor Stellest lenses? Well, there's no significant difference, if you can see, in terms of the p-value before and after adding the Stellest on top of their low-dose atropine eye drops. So of course our study have limitations. Besides the small sample size, there is no control group in our study. It is a short duration of 1 year, and also it's not randomized control trial, and patient also can have variable atropine compliance. Sometimes some patients may skip 1 to 2 days, whereas others may be fully compliant to the eye drops. So next I will discuss 2 case scenarios that can be applied to your clinical practice, and these are the real patients that I see in my clinic. First is a 10-year-old Chinese boy. Parents have high myopia and has been using brand X of myopia control lenses. So you can see while using brand X myopia control lenses on the right and the left eye, patients were started at -2.5 diopters and -2.25 with axial length of about 23 millimeters respectively. So when I see the patient, the next visit, patient has progressed to -3.25, -3.5 with corresponding increment in terms of axial length. So what are your thoughts in your practice if you encounter this patient? What will you do to manage? Will you add on atropine eye drops? Will you change myopia control treatment, say to myopia control contact lens, and so forth? So in this case, I changed the patient from a brand X glasses to Stellest Essilor lenses, and you can see that the slowing down of myopia progression is significant. Patient, after switching treatment, has stability in terms of degree itself or minimal progression. So what this case emphasizes is that using one myopia control lenses, if it has suboptimal treatment, doesn't mean that all the other myopia control lenses doesn't work, because each myopia control lenses utilize different technology in slowing down the progression, and every child responds differently to different treatment, different brand of treatment. So you can always try to change the same modality such as myopia control glasses, but a different brand itself. So this is therapeutic switch. Next case, I'd like to talk about this 8-year-old Chinese boy. Low myopia to begin with is about -1 diopter, -0.5 diopter in the left and the right eye respectively. So following up the patient over the 6 months, we realized that, okay, patient have slight increment in terms of myopia axial length itself, and degree is the same. So decision was made at this point in time to just monitor first. So the next treatment, next visit, patients come in and we realize that, hey, patient has progressed from -1 diopter to -1.5 diopters in both eyes. Decision was made to start the patient on atropine eye drops, 0.025%. So looking at the patient's response initially, yes, there's slowing down in terms of the gradient. If you look at the gradient wise from initial till now, after starting the eye drops, there's slowing down. But yet, patients still continue to have slight progression, -0.25, and also excellent continue to increase. Because of suboptimal response to low-dose atropine alone, what I did for this patient, I add on the Essilor Stellest glasses. And you can see that after adding on, the gradient continue to slow down. Patients eventually have stability in terms of myopia progression itself while on combination treatment, low-dose atropine as well as Essilor Stellest glasses. So that's the end of my talk. I'm happy to take on any further questions or any cases you would like to discuss. Thank you very much for your kind attention.
Thank you, Dr. Fu, for that wonderful presentation.